Good morning. How is everyone today on the almost but not quite rainy day, right? I want to make sure that the captioning is working before I continue talking. Stephen, how's that going? You think we're ready? Hi everyone, please come in and have a seat. We're just making sure the captioning is working before we get started. Can I see a test line of whatever I'm saying to make sure it's working? We have a full house today. Amazing. There we go. Okay, so welcome to our 8th annual Cochlear Implant Day with experts at the Weissman Center. Oh. Are you enlarging the font?
Yes. It's blurry.
I think we'll make it bigger.
And clear.
I hope so. How's that?
Blurry.
It's still blurry? You want to come sit closer up front? No. Okay. Anyway, we'll see how it goes. We'll get started. Welcome to our 8th annual Cochlear Implant Day with experts at the Weissman Center. We have almost 100 people who have pre-registered and are continuing to register for the day. We are so excited to have you here as our guests, and you've seen the program. It's very exciting. I want to begin by thanking everyone who has helped to organize and sponsor today's event. So Shelley Godar, who works in my lab and is an audiologist, has worked so hard on so many of the logistics. Teresa Palumba and Clark Kellogg, who are our both right and left hand managing this event from year to year and work so hard on every single detail to make sure that all of our needs are met. So thank you so much to Shelley, Teresa, and Clark. We also, as you have seen out in the hall, have exhibitors. Of course, the Friends of the Room, AB Cochlear, Medell, and West DHH have helped to sponsor in such a way that we can pay for the live captioning. We also have some additional exhibitors, and we're very, very excited to have everybody here with us today, so welcome. A couple of announcements. The first one is that we encourage everyone who has a question for the panels, and there will be 2 panels, the community panel and the clinician panel. Please write down the questions, and there are note cards that are being handed out during the break. Write down those questions, and they'll be collected, and then I'll be taking questions from those cards rather than passing a microphone around and taking questions from the audience. But please write them down and hand them to me or one of the people collecting the cards. We are also, as we have been doing for a number of these events, doing a live broadcast. This is being recorded, and all the talks and presentations will then be available on the Weissman Center YouTube channel. for the day with experts. So this is very exciting because if anyone has missed today's event or other events, they can go and have a look at the broadcast. So why do I get so excited about this kind of an opportunity, such as a day with experts on cochlear implants? Because being a professor here at the University of Wisconsin, I try to live and breathe this terrific idea called the Wisconsin idea. It's one of the longest and deepest traditions that we have here at the University of Wisconsin. And the basic idea is that the education should influence people's lives beyond the boundaries of the classroom and the campus and throughout the state. So for more than a century, this idea, the Wisconsin idea, has become a guiding philosophy for how we do our work. And I think of the cochlear implant research and clinical work that we do as being the embodiment of the Wisconsin idea and bringing the community here together to learn and discuss what is going on with people's lives is one of the most meaningful things that we do. And the idea is that, as I said, education should influence people's lives. So what we try to do is identify new problems, conduct research to understand how to solve the problems. We educate our students. Some of them are here today with us. We reach out to our community, and our community folks are here with us today. We connect with industry. We partner with industry to improve the work that we do. And then, of course, we identify a new problem, and that loop starts again. So here we are today. It's not a coincidence that we're running the program at the Weissman Center, because this building, this place, is dedicated to advancement of knowledge about human development and disabilities, neurodegenerative disease, and a lot of issues that people face throughout the lifetime. And the work on hearing loss and cochlear implants I think of as exemplary of those issues. But we also have other days that focus on other issues, including a day on autism in January, Down syndrome, and cerebral palsy. So the Day with Cochlear Implants, which is one of 4 events throughout the year, all exemplify the kind of work that we are doing. So the overarching goal of the work that we do at Weissman has what we call the 3 C's. The causes, which is to look at environmental and genetic causes. The consequences, which is what goes on for the individual, their family, and society. And of course, we're always thinking about potential cure and treatment. Hearing is a great example of where, for example, stem cells, child development, clinical grade drugs, and brain imaging all come together to meet those 3 C's going back: the cause, consequence, and the cure and treatment. So today's topic on cochlear implants, as you'll hear from our experts, you can lose your hearing from a lot of different reasons. It could be meningitis, accident, ototoxicity, noise, heredity, or unknown causes. And here we see examples of healthy hair cells or damaged hair cells. And eventually, if too many hair cells are damaged, that is when someone becomes a candidate for cochlear implant. And patients make a lot of different choices. Should I get an implant? Should I keep using my hearing aid? When is my hearing aid bad enough so that I should start using a cochlear implant? If I choose to get a cochlear implant, what is the process like? Will I be successful? How often do I need to see my audiologist or speech pathologist? How much does it cost? Should I get 1 or 2? Many more questions. These are the questions that we are working on. So cochlear implants are kind of a poster child or a hallmark of translational research, because we go straight from engineering to treatment. It's not a cure, but it's a really great option in terms of treatment. So we combine research, discovery, treatment, education, and outreach. And we have a really great collaboration between us here, the hospital, the Department of Communication Sciences and Disorders, and of course our community. So here's today's program. I've given a brief overview. And then our next speaker is Dr. Joseph Roche, who is one of our premier surgeons here at the Weissman Center. And it's really my pleasure to introduce Dr. Roche, who's been an amazing surgeon and collaborator with us. So please help me in welcoming Dr. Roche. And then is Clark changing the presentation?
What do I do?
I don't know. Then I think perfect. And then I think you just go here.
There we go. Okay, thanks. So, thank you for your attendance. So I'm one of the cochlear implant surgeons here at the University of Wisconsin. I serve as the director of the Cochlear Implant program, and I also, which is just part of my practice, another part of my practice works in looking at other ear-related conditions that don't require cochlear implantation, skull-based surgery, and I partner with our neurosurgery colleagues a lot, helping to treat different types of central nervous system tumors. So I don't have any financial disclosures, unfortunately. Oticon and there's a totally implantable device that I'll be talking about. They're not available in this country yet, and nor are they FDA approved, but we will discuss those briefly. So my outline today is I'm just going to give a quick overview of hearing and sort of the anatomy that's pertinent to cochlear implants, sort of influences how we think about innovations, where can innovations occur.
We can't hear you very well back there.
Is this better? Do we have a... No. Is this better? Okay. So I'll be talking about just some basics of hearing anatomy and how it influences both implantation as well as there are some targets for innovation. And then talk about a couple different areas of cochlear implantation that have changed the last couple years since I gave my first talk here. This is by no means comprehensive of all the technological advancements, biological advancements, audiological advancements, but just sort of a flavor of some of the things that are being worked on currently in the community of researchers and surgeons. So hearing involves a number of different structures. I sort of break them, my simple surgeon mind breaks these down into sort of three main components. The first is the outer and middle ear, then there's the inner ear, and then there's the brain and central nervous system. And each one of these plays a role. So the outer and middle ear are involved in collecting sound from the environment, taking that and transmitting it to the inner ear where it can be further processed. And if someone were to have a problem such as a tumor or a bony overgrowth or a hole in their eardrum, some sort of a disruption of the bones that help conduct the sound or the ossicles, then they have what's called a conductive hearing loss. Sound does not conduct from the outside world into the inner ear and rest of the central nervous system. This is not a type of hearing loss that is treated by cochlear implants per se, but oftentimes they can run together.
You're tall, but can you get a little closer to the microphone?
Well, not right. Okay, sorry. The second, next sort of station I think of in hearing processing really is the inner ear and auditory nerve. The inner ear composes do we have a laser pointer? It composes the cochlea, which is right, the snail shell looking structure right here, which is where sound energy, the vibrations of sound, is then converted into an electrical signal, which is then transmitted by the auditory nerve up to the other parts of the central nervous system so it can be turned into a car backfiring, your friend talking to you on the street, a bus passing you, etc. For people who have diseases in either the cochlea, the nerve, or oftentimes a little bit of both, this is where cochlear implantation can be helpful when other treatments are no longer providing the benefit that patients and providers are hoping for. So treatment for hearing loss just in general depends on its configuration. Is it the conductive component? Is it the inner ear? Is it the nerve? Is it a combination of the three? And it can also is based on the severity of the hearing loss. For individuals who have a relatively mild or a low amount of hearing loss, oftentimes just using behavioral strategies can be sufficient. Sitting closer to your speaker, using a personal assistive listening devices such as TV ears or whatnot can be effective. For individuals who have a moderate hearing loss but who maintain clarity, meaning that with using a hearing aid which turns up the volume, if you can understand the words that are being spoken, this is really a superior option for most individuals. But where cochlear implants fit into the treatment strategy paradigm is when individuals have a significant hearing loss where there is a communication deficit, meaning that you can hear the sound but you can't turn that into something that you can process. You can't understand the sound or the words that are being spoken to you. Many times, not in every circumstance, but in many times, cochlear implants can provide benefit for communication by bypassing the hair cells that are typically damaged to a little bit larger of a degree, and by stimulating the hearing nerve directly, bypassing the majority of the pathology. So the general concept of a cochlear implant is that there's a couple of different parts that we have to consider. The first is that there's the system itself, which is composed of an external processor, which takes the appearance of a fancy hearing aid. You wear something behind your ear or near your ear, which this picks up the sound and then turns that into using a processing strategy, which will be talked about a little bit later, turns that into something that can be utilized by the internal device, which is then implanted under the skin. And there's no connection between the two. They communicate by radio frequency, not dissimilar to how you might charge your cell phone or another electronic device wirelessly. The next parts are the cochlea and the auditory nerve. And you have to have a cochlea in order to put an implant in it. It sounds obvious, but sometimes people can have obstructions, scar tissue that forms. They can be deformed, they have congenital malformations of a cochlea which don't accept an implant to the same degree. And you also have to have an auditory nerve. Some people are born congenitally without auditory nerves. Other times the nerves can be affected by different disease processes. And so that can affect the success that individuals can have with these devices. We take advantage of the layout of both the cochlea and the auditory nerve. There's a pattern to the cochlea such that high-frequency sounds are detected right at the very beginning of the cochlea or the base, and there's a nice gradient as we traverse through the spiral to lower-frequency sounds. And the implant, as it's slid into the cochlea, has different electrode contacts, which will stimulate a very particular spot of the cochlea and then hopefully the nerve, and take advantage of those neural patterns so that we can try to recapitulate sound. In other words, we can try to do what the ear does naturally, but we can do that with an implant. So areas that are prime for innovation would be the processor and the processing strategies. And Dr. Tucker is going to be talking about this later with some of her amazing work here at the Weissman Center. As well as there's now the new off-the-ear processors, which are becoming a bit more commonly utilized by patients. We can also try to improve the electrode. This is sort of the meat and potatoes of how we get the stimulation into the brain. And so trying to improve the patient-prosthesis interfaces is, of course, an area of active research. As well as we can try to improve the way these devices interact with other medical interventions. Human beings aren't just ears, they have other disease processes, other requirements for treatment, and sometimes cochlear implants based on their components or requirements for other types of treatments can interfere with that. And so we have to take that into consideration. And there's some new innovations that can help with all of this. So just starting with off-the-ear processors. So there's two that are commercially available right now. There's the Kanza, which is by Cochlear Americas, and Rondo, and the Rondo 2. And these devices don't take the same appearance of a on-the-ear device. So for everyone's seen hearing aids, typically these are either in the ear or worn behind the ear, and cochlear implant processors are typically the same. Off-the-ear processors have some advantages. They can be a little bit more discreet, and they don't have some of the tactile stimulation of the ear. In other words, some people, their ears are small, they can't, they don't like the sensation of having a device sitting right on their ear, and these can be an option for these individuals. Not surprising, because they don't have the same ear hook to hook onto the ear. These require a stronger magnet because they're heavier, which can make them a problem for dislodgement, which it can be a problem. Additionally, with a stronger magnet that holds the processor and the internal device together, with a stronger magnet, you are actually compressing the skin a little bit more tightly. So it can be, if someone has poor thin skin, they have poor wound healing capacity or other things, this may not be a great option for them. So these are not a panacea, because you can get some skin breakdown occasionally with these. And the lastly, the Rondo 2, which is relatively newly on the market, comes with a couple of new features, such as wireless charging, as well as a rechargeable battery, which is a lot of patients are finding particularly attractive. So moving on to electrodes. So when I think about electrodes, I really think of them as coming in two different types. There are electrodes that tend to take the shape of the cochlea as they are inserted. These are soft, or they are lateral wall, so there's an inner wall of the cochlea and an outer wall with the nerve running towards the center. And flexible electrodes will come in, and they will go straight until they hit the outer wall of the cochlea, and then slowly change its shape as it conforms to the outer wall of the cochlea as it's inserted. Some of the advantages of the lateral wall electrodes is that they can potentially be softer to the structures of the inner ear, right? You can imagine that there's lots of different tissues that are in the inner ear that are important, and if you like to try to preserve as much of the natural anatomy as you can, so these provide an option for that. And this is really what the first electrodes that were designed back in the 70s and 80s were based on. The contradistinction to this is electrodes that, when they're placed, as they're inserted, they will slowly take a shape that conforms to the inner wall of the cochlea and hug what's called the medialus, or the center of the cochlea, which is where most of the nerve fibers are found. These are pre-shaped electrodes. Advantages of the pre-shaped electrodes, or at least what we believe, is that by bringing the electrode contacts in closer apposition to the nerves, you can use lower stimulation currents and potentially improve the interaction of the device with the nerve. And there are examples from all of the different companies. So Med-El has their electrode portfolio, all are lateral wall oriented, but Cochlear Americas has 2, as well as Advanced Bionics has 1 that are all lateral wall oriented. From a perimedialar or medial wall oriented, there's 2 from Cochlear Americas and 1 from Advanced Bionics. So there's actually two new electrodes, one from each type, that have been on the market in the last couple of years that I will just highlight today. So the idea behind pre-shaped electrodes, as I already mentioned, is that you want to bring the nerves and the electrodes closer together. And this is a picture provided by Cochlear Americas demonstrating just that. The nerves that are being stimulated live here in the center of the cochlea, the medialus, and these are the electrode contacts right here, and they're hugging the medial wall of the cochlea, and they're as close as you can get without breaking the bone. And again, the idea behind this is that you can use less current, so the current will spread spherically out from the electrode contact, and if you're sitting at the lateral wall, it takes a larger sphere of electricity to stimulate that nerve, and so as a result, you stimulate more nerves and you lose some of the precision that you can get with the electrode contact. So potentially you can have less what's called channel interaction, where the different either neural channels or electrode channels will cross over and sort of slur together into one percept, which is not as precise. The downside is that not every cochlea is exactly the same shape. Not every insertion goes as planned, and if you have a more rigid and pre-shaped electrode, you have the potential for traumatizing the soft tissue structures of the ear, which are highlighted here, this is where the hair cells would live in the scala media. And so you would prefer to not damage these if you can avoid that. So currently available electrodes include one from Cochlear Americas, which is the Contour Advanced. This was their first iteration of their perimedialar array, as well as one from Advanced Bionics. And the way that they conform to the cochlea is they're held straight with a stylet, and as you place the electrode, you slowly advance the device off of the stylet, and it will then curl to the shape for which it was created. The newer device that's on the market, or electrode, is one that uses an external sheath. In other words, it's a smaller profile for the device because you don't need an internal stylet, and you use this cylindrical sheath that holds the device the electrode in its configuration, and you slowly advance the electrode out of the sheath so it can take its shape. And the idea behind this is that, number one, you can potentially reuse this if the electrode positioning is not perfect, but that because you don't have to have an internal stylet, you can have a lower profile, so a smaller. You can take advantage of some of the lateral wall smaller electrode configurations. So just to sort of show this. So the cochlea, where you place the electrode, which is in this compartment here, is large at the base, or the very front of the cochlea, if you will, but it becomes progressively smaller as we go from base to apex. And so an electrode that fits easily when you first place it, by the time it gets to 1.5 turns, is now interacting with all the soft tissue structures because the tube is getting smaller. And the idea behind this new slim medialar electrode is that you can then, because it's smaller, so this is the original electrode, and this is the newer, it's been out for 2 years now, slim medialar electrode, you can see that it's much smaller in profile, and you're much less likely, potentially, to interact with the soft tissues of the inner ear, causing less damage, preserving more structures, potentially improving hearing outcomes. So this is just highlighting that the nerve is sitting here, and the soft tissue structures you want to save are sitting further away from the smaller device. On the other hand, lateral wall electrodes have a very good profile, and there are reasons you may want to consider using a lateral wall electrode, and one of the newer ones that's on the market is actually the Slim J by Advanced Bionics, and this has a very good safety profile as well. It's not indicated for hearing preservation, but in the people who have used it for that have suggested that it performs similarly to other hearing preservation electrodes. So we now have 2 new electrodes to the portfolio to choose from when we're trying to decide what type of a device, what electrodes to use for each individual. So, moving on to how does this device interact with other types of treatments? Well, the big bugaboo with cochlear implants when it comes to other treatments is really that they have a magnet, which interferes with MRIs. MRIs are becoming much more commonly utilized across all medical disciplines. We used to order a lot of CT scans in my specialty, otolaryngology, and I'd say it's the rare patient who I'm getting a CT scan on because MRIs provide superior soft tissue definition of all the structures. Additionally, there's no ionizing radiation, and while the risk of the radiation exposure from a CT scan is relatively low, it is not insignificant, especially if you need to get multiple CT scans for whatever your treatment condition is. And so the MRI is advantageous. Additionally, it's becoming the test of choice for evaluation for stroke, different types of CNS disorders such as Parkinson's disease. You can even find neural signatures in MRIs of migraine, and so they're commonly utilized for headache disorder evaluations, as well as screening for cancer, such as this is an individual unfortunately has lots of brain metastases that are small enough that you may not necessarily see these on a CT scan. So there are reasons you would want to use an MRI. But the problem is that you use 2 magnets to hold the internal and external device together. And if you've ever used 2 magnets at home, you know that if you put the 2 north sides together, they repel each other. So they interact. So the huge magnets, the 3 Tesla, 5 Tesla magnets, 1.5 Tesla magnets you use for the MRI, will interact with these very small magnets in your cochlear implant. So if you take the magnet out, you see that there's still a shadow over the brain, which if you're trying to image something in this portion of the central nervous system, you're not going to see it. And if you leave the magnet in, because you're going to be getting an MRI of your hip, then really you lose any capacity to image central nervous system structures. The shadow created by the interaction of 2 magnets is just too big. Additionally, there's force put on the magnets, and they can actually move, they can migrate, they can flip. And additionally to that, because there's all this vibration that comes, they can actually get some increase in, they can actually start to warm up. So it's not a trivial interaction. So it used to be that we couldn't get MRIs in any patients who had cochlear implants unless we remove the magnet. Well, now all 3 manufacturers have implants that at least will accommodate MRI to some degree. So this is termed MRI conditional. So some people like to say MRI compatible, but what this means here is that under certain conditions, patients with a cochlear implant can get an MRI safely. So for Med-El, their strategy for this has been they have a magnet that will actually spin. When you do an MRI, they create these pulsed fields that create a force, and with the spin of the magnet being allowed to spin will then dissipate that force on the magnet. And so there's no additional treatment needed as long as your MRI is 3 Tesla or less. For Cochlear Americas, it depends on the type of MRI. So 3 Tesla is sort of the gold standard nowadays, but 1.5 Tesla, which is a weaker MRI, is what is most commonly utilized in the community. What you can do with a Cochlear Americas is they will provide you with what's called a head wrap and a card that will you will wear a head wrap that will compress against the implant to prevent the magnet from flipping. If you need a 3 Tesla MRI, then we actually have to do a small procedure where we'll take the magnet out, get the MRI, and then put it back in after the MRI is completed, if that's what the patient elects for. So again, you can get it, but it takes a little bit more effort. Advanced Bionics recently came out with a different type of a magnet, one that has rotatable magnetic cylinders. And again, these will then align to the magnetic field and dissipate the forces that are being put on the magnet by the MRI. So again, with this, they're MRI conditional up to 1.5 Tesla with a head wrap, and 3. If you have to have a 3 Tesla MRI, then we can take it out. But the point is, you can still get an MRI, and if you were to develop a medical condition where MRI is going to be paramount, say a melanoma treatment, where MRIs are critical to determining the success of the treatment, you can still have your cochlear implant and get the MRIs as needed, as long as those are taken into account by both the person ordering the MRI as well as the cochlear implant surgeon. So lastly, a couple of things that I think will be in the not too distant future I think are relatively exciting. The first is that there's a 4th manufacturer that's based in Europe. So Oticon Medical is one of the larger hearing aid companies in the world, and they purchased a French company which created this, what's called the Neuro ZTI device. Some innovations for this device that I think are pretty interesting are that instead of having their stimulator, which picks up the information from the external device, as well as the processor and the magnet are all in one smaller compartment. They also, all of their electrodes are lateral wall oriented, so there's a couple of different types. So for hearing preservation, they have, or for where you want to preserve soft tissues, they have what's called the EVO character. They also have a classic carrier as well. This is currently in clinical trial in Europe. It actually has a CE, which is their version of the FDA. It was approved, and right now it's in clinical trial in Canada. The results are not out yet, though, so we'll see. But this may be potentially another vendor on the market that could provide some benefit to patients in the future. Lastly, and this is where I think this is a lot of people have been thinking about this for a while, is totally implantable systems. So wouldn't it be nice if you could put something under the skin, you don't have to wear an external device, and you can go all about your daily life. If it rains, it's no big deal. If you go swimming, it's no big deal. Can't get knocked off, so it's good for young children who are rambunctious. And so in 2008, there was a study that was published in Australia looking at a Cochlear America's device that's a totally implantable cochlear implant. So it looks very similar to what I've shown previously. There's an RF coil that's mainly used for charging. There is the electrode, which is this is the Contour Advanced electrode right here. There is a speech processor and stimulator, so both the external component and other implants and internal receiver stimulator are in one component, and a microphone that sits under the skin. So what's nice about this is that all the components are in one location. So again, less conspicuous, there's no water issues. There are some disadvantages to this strategy, which is that there has to be an internal battery, and at least in these studies, it takes a long time to charge a battery through radio frequency, at least a battery that's going to be required for normal use. Additionally, you have to have an internal microphone, which is, in other words, you're taking the microphone that you'd like to be exposed to the air, and you're putting it under all that soft tissue. So that's going to dampen the sound, change its transfer characteristics. And so this is sort of where people have been spending a lot of time trying to come up with other strategies. Put a microphone next to the tympanic membrane, use the ossicular chain, put something under the skin of the ear canal that you could utilize that might be better than having a microphone sitting under the soft tissue of the scalp. Additionally, now Tesla has really changed the game as far as rechargeable batteries go, so this may not be as much of an issue, but when we first started thinking about these devices, there's probably going to have to be an explant reimplant strategy for the battery for this. We have to change batteries on pacemakers, deep brain stimulators, etc. We're probably going to have to change the battery here. And every time you expose the implant to change a battery, etc., you're exposing that to the outside world and increases your risk for infection. So not a panacea, but potentially an interesting development, hopefully, in the not-too-distant future. So lastly, I'll just put a plug in for our program at UW. We have a comprehensive team of allied health professionals, audiologists, speech pathologists, researchers, surgeons. We treat both pediatric and adult cochlear implants from initial evaluation to lifelong programming. And we now offer a comprehensive range of solutions. We offer Med-El and Cochlear Americas currently. We have a contract with AB. We're just waiting for the final administrative approval, and then we'll be offering all three companies. So with that, I thank you for your attention. Hopefully you caught most of it. And I'd be happy to take any questions.
So you have 3 minutes for questions, but you have to repeat the question because there's no microphone.
Sir.
When I received my first implant 20 years ago, I was given no choice, or we say no matter what device I was receiving. Is one, it's not that as a choice, at that point in time, I had much of much awareness, much to ask. But now, our choice is given. I mean, when I have reasonable or often active house with decision making.
So the question is, if I can restate your question, is that when you got your implant, there was not an option given for you to use a different company or choose an electrode, and then is that option given to patients today, and what is the relationship between the team? So at the University of Wisconsin currently, we unless there is a medical indication to choose a particular device or electrode, which one example might be cochlear obstruction. Using a soft electrode is not great when you have an obstruction. You want to have something that's more rigid that you can push past. So that I may suggest to patients, you really need to consider a styleted device, which would mean really AB or Cochlear Americas. Absent a medical indication for a particular device, I leave it up to the patients and their families to decide. And there is not any compelling evidence to suggest that's been reproduced that suggests that one strategy of device and electrode is better than the other. I mean, there are studies that would suggest maybe perimodality is better, then there are also studies that suggest lateral wall is better. So the jury is still out. So at this point, I let patients choose because there really isn't a significant difference when we look at testing.
One more quick question.
Sure. You in front, ma'am.
Thank you. I have an acoustic neuroma requiring semi-annual MRIs,
Mm-hmm.
and my understanding is that Medel is the only device that could withstand an MRI.
It would. So the question is, you have an acoustic neuroma, which is a certain type of skull-based tumor, or brain tumor, that is being surveilled with MRIs repeatedly. And the question was, is Medel is the only device that can accomplish that? I would say that is. I would disagree with that. I think that there are a lot of different strategies from different implant manufacturers that you could utilize. Certainly, there are some advantages to the synchrony, but I think all three manufacturers you could pick from that. Should that be an option you need in the future? It would just require a intelligent planning beforehand to recognize what type of MRI you're going to need, and then tailor that. So if you have to have a 3 Tesla, well, then maybe Medel might be better because you don't want to have to be taking the magnets out every 6 months. On the other hand, if a 1.5 is fine, then all 3 manufacturers should be able to offer you an option. I guess that'll be it. Thank you.
Thank you.
Thank you so much to Dr. Roche for an incredible presentation, and he will be available today for further questions, also during the break as well, and on the clinician panel that will follow the presentations.
And Vijay, if you can just give me 1 second to go back up and read.
While I introduce you, so I'll just introduce you very quickly. Okay.
So it's my pleasure to now introduce Dr. Vijay Ishwara, who is currently a visiting assistant professor in the Department of Communication Sciences and Disorders. She has been teaching many of our courses while at the same time working here at the Weissman Center as a researcher. And she also came to us from Canada 2 years ago, where she did extensive postdoctoral research and has terrific expertise in a number of areas. And she will be talking to us today about one of the areas of research that she's continuing to collaborate on as she also is setting up her research program here at the Weissman Center. Yeah, go for it. We want to make sure it's all working well.
Vijay has sound. I want to make sure we can hear it.
Oh, that's great. So without further ado, it's my great pleasure to introduce Vijay Ishwara.
Thanks, Ruth. Can everybody hear me okay? Okay. I usually get louder as I keep going. So good morning. Thanks everyone for taking the time out for this event on a Saturday morning. So in this talk, I'm going to be describing everyday hearing experiences of cochlear implant users. I'm going to mainly focus on children with cochlear implants, but I'll also be drawing a lot of examples from adults with cochlear implants from work from other labs. So throughout the talk, I'm going to try to use the term CI for referring to cochlear implants. So our goal of recommending hearing aids or cochlear implants to children who have hearing loss is to give them appropriate hearing experience so they can develop auditory behavior, speech understanding, or any communication skill like the way normal hearing children would. But a lot of factors affect the hearing experience that we hope to give them. One is the degree of hearing loss. So worse the hearing loss, lesser the exposure to sound they have. Age of identification and age of intervention matter. So earlier the age of identification and earlier the age of intervention, we are reducing the amount of deprivation these children have. So their hearing experience, or the hearing experience tends to be better and longer for these children who are intervened early, or receive intervention early. And use of 1 versus 2 devices also matter. So children who wear 2 devices tend to do a little bit better in speech understanding, especially in the presence of competing signals. And a lot of them are also able to tell where sounds are coming from when they have 2 devices as opposed to 1. And there are a lot of different factors that affect hearing experience. But recently, we've been interested in looking at factors that affect hearing experience on an everyday basis for these children. So in particular, we are looking at consistency in everyday device use. And 2, we're interested in looking at the types of sounds that these children are exposed to when they are wearing their devices, or CIs. So the first question is, how do we actually quantify device use and the types of sounds children are exposed to in their everyday environments? So if it's a fairly old child, we could interview the child. They could tell us about how long they wear their CI, and they could describe their events from every day, like attending class for a few hours, commuting by bus, and so on. So we could get an idea of what their everyday experience is like. If it's a much younger child, we could interview the parent, and they could tell us how long they think the child is wearing their CI, and what are their everyday activities, like playing with peers and napping and so on. So we could get an idea of what type of sounds a child is exposed to when they're wearing their CI. But as you all might be thinking, this is quite an onerous process. So it takes a lot of observation, and at the time of appointment, they have to recall what they observed. Luckily, there is an alternate way now. So there is a new feature called data logging in CIs that enable us to track CI use and the types of environments CI users are in when they're using their CIs. So we can think of data logging as fitness trackers that we wear all day, like the way fitness trackers could track the number of steps that you take without any extra effort from you. CIs, or data logging in CIs, could be tracking in the background the number of hours the CI is being used and the types of sounds CI users are exposed to without any extra effort of that CI user or the family itself. So it's quite convenient. So I'm going to show you an example of a data log. A data log divides the 24-hour day into the time the CI is off or not in use. The CI is on. So here, as George explained, we have different components to a CI. So when I'm saying on, I don't know if you can look at my pointer. So when I'm referring to on, so I think I can.
Do you want to try to use this one? This might be better.
Thank you. So when the device is on, the external components of the CI are on and they are in position, so the external component can actually talk to the internal components to conduct sound through. So that's what I refer to as on. And the data logging could also be tracking how long a CI is disconnected. That means that the device is worn, the CI is actually on, but the external components are no more talking to the internal components, so there is a disruption in hearing. So as you can imagine, tracking the time the device is disconnected and the number of times it's disconnected is actually important for us to know, because there's a disruption in hearing, and that disrupts how much hearing experience they get. But it is pretty impossible to be accurate when we are trying to track this manually, by manual observation. So data logging is convenient that it is able to track that in the background. So data logging can also monitor the nature of sounds in the environment. So the sounds in the environment that a CI user is in. So So again, it's like a fitness tracker that would tell you the number of steps you've taken, and of the number of steps you've taken, how many floors you've climbed in that time, and also how many active minutes you've had getting your heart rate up. So data logging similarly would keep track of all the sounds that's entering the microphone of a cochlear implant and classify that into 6 different scenarios. And the 6 include quiet, which means not much is going on. Music, I don't need to describe that. Noise would be noise like traffic noise or air conditioner and things like that. Wind. And then we have 2 categories for speech. One is speech in quiet and one is speech in noise. So speech in quiet means that a child is exposed to a speech signal without any other competing signals in the background. But speech in noise means that there is a speech signal, and when that speech signal is on, there's also some other competing signal like traffic noise or other people talking in the background. And we care about differentiating speech in quiet and speech in noise simply because speech understanding in noise is much more challenging. And just to make the point, I have a few samples. I'm going to play the first sample, and I'd like you to guess what the sentence is.
We find joy in the
Did anybody get that? I'm purposefully playing the toughest one, so I give you the opportunity to guess. So I'm going to play that again.
We find joy in the
Any guesses? It is very tough. I couldn't get it. So the sentence is, we find joy in the simplest things. So I can play it again the second time around, and once we're familiar with the sentence, it becomes a lot easier.
We find joy in the
Now, that is a lot of noise for us to understand, and that was my point. But when the noise reduces, it becomes a little bit easier.
We find joy in the simplest things.
And it is the easiest when there is no noise or when speech isn't quiet.
We find joy in the simplest things.
So the point in tracking how long children are exposed to speech in quiet versus noise is that we could get an idea of how challenging these listening environments are for these children and how much effort they're probably putting in to make sense of what's going on. So our goals of our study were to evaluate daily device use and factors influencing it, the nature of listening environments children are exposed to, and lastly, the impact of everyday listening experience on speech understanding in children. So for this study, we had 146 children who wore 1 or 2 CIs. Children who wore 1 CIs were unilateral users. Some of them were unilateral users, meaning they had hearing loss in both ears, but they only wore 1 CI. Some of them were bimodal users, so they had hearing loss in both ears, but they wore a hearing aid on one side and a cochlear implant on the other. A lot of them had 2 CIs, and many of them received both their CIs in the same surgery, and we refer to that as simultaneously implanted. And many of them received the 2 CIs in different surgeries, sometimes several years apart, and we refer to them as that as sequentially implanted. So I'll go over results for our first goal, which is daily device use and factors affecting that. So here's a graph, and what I'm showing you here is the distribution of everyday CI use in the 146 children. So the height of each bar tells us the number of children who are wearing CIs for the number of hours shown on this horizontal axis. So we see that there are a lot of children who wear their CIs for less than 5 hours a day, but there are also a lot of children wearing CIs for many, many hours a day. On average, in the entire sample, children were wearing their CIs for close to 10 hours a day, which is great. About 64% of them were wearing it for more than 9 hours a day, which is also great, but we do understand that there is a lot of variability. So in an attempt to understand what makes some children wear their CIs more often or more frequently than the others, we looked at some demographic factors, and one of the main influencing factors was hearing experience. So longer the child was hearing with a CI or before they got a CI with a hearing aid or their natural hearing, they were likely to wear their CIs for longer every day. On the other hand, children who had longer disconnect time, so they were wearing the device, but the device was off and they were not hearing sound, that reduced their everyday use, and that's not surprising. So we also tried to look at who was more susceptible to longer disconnect time, because that's affecting how much they use the device every day. So longer disconnect time was associated with more frequent disconnects, and frequent disconnects was most common in younger children. So children who were under 3 to 5 years of age had about 50 to 100 times, the CI would disconnect about 50 to 100 times a day, which is very many. So it's not surprising that younger children have more frequent disconnects, because they're walking around a lot more, they're probably having more frequent falls, they are in like strollers, car seats, and there's more chances of disconnects. But the sheer number was surprising to us, and it's really highlighting what a practical challenge it is, or it could be, to keep the implant in place to achieve consistent device use in the early ages of life. So that takes me to our next goal, which is the nature of listening environments. And a quick recap. So a data log divides the time the CI is on into 6 different categories. And I'll go over the 4 non-speech. I'll go over the non-speech ones and then the speech environments. So I'll orient you to the graphs here first. So we have age along the horizontal axis going from younger ages to older ages. And we have hours per day on the y-axis, going from fewer hours to more hours at the top. So I'll go over data for the quiet environment first. So here, each dot is a child. So what we see is that the hours spent in a quiet environment is quite variable across children, regardless of age. But overall, there is a tendency for an increase in the time spent in a quiet environment as age increases. And that's probably indicating more alone time, spending time like doing homework or studying and so on. Relative to a quiet environment, children spend far less time in an environment where there's only noise. And there is a mild or marginal trend, if you will, of increase in that, even though overall the time spent is still very low. In contrast to quiet and noise, the time spent in an environment where there's a lot of music in the background is higher, tends to be higher at very young ages, and that tends to reduce over time, except for this one child there. So exposure to speech also tends to vary by age, and now I have the same format of graph, hours by day as a function of age. The number of hours spent or exposed to speech in a quiet scenario tends to increase in primary to middle school, and then it decreases after that. But what's interesting is that the time spent in speech and noise also follows the same pattern with age, but it's a lot higher than what we see for speech and quiet. So children are nearly twice as likely to be listening to speech in a noisy environment compared to listening to speech in a quiet environment. And it happens that it's not just children who are listening to speech in a noisy environment, the trend continues in adult life. There's another study that collected data logs from 850 adult CI users from 13 different countries, and they found pretty much the same thing. So we are twice as likely to be listening to speech in a noisy environment compared to listening to speech in a quiet environment. So this data is really telling us that, one, we just live in a noisy world, and two, we have to be mindful about using additional technology to improve the quality of signal, so the effort spent listening to speech and noise is lesser. So that brings me to the third goal, which is looking at the impact of everyday hearing experience on speech understanding in children with CIs. So again, I'll orient you to the graph here. So we have speech understanding on the vertical axis going from poor speech understanding at the bottom to good speech understanding at the top. And we have daily CI use across the horizontal axis going from less frequent use on the left to very consistent use on the right. And again, each dot is one child. So what we see is children who have really good speech understanding tend to be the most consistent device users. And there is a lot of variability, but there is a tendency that children who don't use their CIs very often tend to have poor speech understanding. But what's interesting here is that environment acoustics actually did not matter. So the time that children spent listening to speech in a quiet environment or in a noise environment didn't really predict how well they understood speech when we measured that in a clinic. So all the data that I showed you in this graph is a subset of this 146 children who were old enough to participate in a speech test, and that included children with 1 or 2 CIs. But what I'd like to focus on next is children with 2 CIs. And specifically, I want to focus on the difference in speech understanding between their years. So here we're measuring speech understanding in 1 year first, and then the next year, and then we're looking at the difference between the 2 years. And we are interested in this because a lot of children traditionally got only 1 CI. And as we've learned about the benefits of using 2 CIs over 1, a lot of them were later on in life offered a second CI. So the hearing experience between the 2 CIs are different, so we wanted to look at how that impacts or how that affects speech understanding between the years, or difference between the years. And what we found was that the difference between the 2 years, the difference in speech understanding between the 2 years was related to the time between the 2 surgeries. So longer the time delay between the 2 surgeries, larger the difference between their years in speech understanding. But the good news is that that difference could be reduced by consistent device use. So what we also found is that among children who were implanted sequentially, the difference between their years in speech understanding was much lower if they used their second CI consistently every day. So that brings me to the summary. So data logging, a feature available in most cochlear implants today, allow monitoring of device use and listening environments, and that helps us identify several factors that we could intervene and to improve the hearing experience of these children. It's more common for us and for children to listen to speech in the presence of a competing signal than in a quiet environment. So we have to be mindful about improving the quality of the signal, not just in classrooms, but anywhere throughout the day. And higher consistency in device use is related to better speech perception. So again, this is just reinforcing the point that appropriate hearing experience is really essential exercise for our ears. So with that, I'd like to thank the research team and the clinical team that helped me gather data in Canada, and thank you for your time. And, I'm happy to take any questions. We have 5 minutes for questions. Yes. Yes.
You did not mention, just about anything, but I know you didn't mention processing throughout used by any individual. Did that make a difference, or did it not make a difference, or was it just impossible to track?
So the question is, did processing strategy make a difference? We did not particularly look at that, but all of these children wore cochlear devices. And they were all wearing the N6 processors, because that's the processor that introduced data logging in cochlear implants. So we did not look at differences in programming within that.
I mean, like music or group or quiet or I forgot the name.
Right.
What kinds of noise?
We did not look at that. Yeah.
Do you think it makes a difference?
So the question is, does the processing strategy depend on the type of sounds they're exposed to, or does the time they are exposed to a particular type of sound depend on the strategy they are using?
He's asking if the different programs make a difference.
If the different programs, we did not look at that. So we did not look at if different processing strategies or different programs actually made a difference. Yeah.
One more question.
Yes.
Is it beneficial for a kiddo to wear their cochlear implant while they're napping so they can kind of pick up on the ambient sounds of things happening while they're sleeping?
I've heard.
Repeat the question.
Sorry. The question is it beneficial for a child to be wearing a cochlear implant when they are asleep? Sorry? I don't know the right answer to that question. Yes, we all hear it in our sleep too. Anecdotally, I've heard that some children want to keep their CIs on even when they want to go to sleep, even when they're going to sleep, but most children don't. Yeah. Thank you.
Well, thank you so much, Dr. Ishwar, for a fantastic presentation. We have time now for a 15-minute break, so we'll stretch our legs, and please come back in 15 minutes for the continuation of our program. How are you?
I can make it bigger. So.
Hi, everyone. I think we still have a few people in the hall, but we'll get started. Before we do, folks who are using the cart, we have increased the font size. Is that better, or do you want it to be bigger? Because we can make it bigger. Is that all right? Or go like this if you want it to be bigger. Okay, a little bit bigger. Thank you, Stephen. So it's my pleasure to...
Sound.
I'm sorry?
I said it's not the type.
It's not.
Sound.
It's the sound, yeah. Well, we're doing our very best to accommodate everybody. Thank you for your patience. So it is my great pleasure to introduce our next speaker, Dr. Tanvi Tucker, who recently got her PhD after 6 years of working very hard on a number of incredibly challenging and important projects that have to do with how we can improve cochlear implant processing down the road. It is my great pleasure to introduce Dr. Tucker. Thank you.
Hi everyone, thank you for being here. My name's Tanvi. So I'm going to be talking to you about improving sound localization abilities in listeners who wear cochlear implants, and specifically bilateral cochlear implants. Okay, so here we have a scene, a noisy cocktail party, which I know all of you understand is very overwhelming and loud, and can be kind of difficult to hear in those environments. So I'm going to point out Bob here, who enters the party, and he's trying really hard to listen to Sheila over here, who he's trying to eavesdrop because he really likes her, but how does he accomplish that task? Well, if we focus just on this area of the party, you can see that he's able to separate out her voice because she has a slightly higher pitch in her voice, whereas the male talkers to the side of him have a slightly lower pitch in their voices, so it becomes kind of easier to separate these sounds out. But there's also one other piece of information that Bob is able to use, and that is the location. So Sheila is located to his right-hand side, and he can separate her voice out because she's to the far right. And the male talkers are now situated to his far left, so he knows that they're spatially separated at this party. So we must, our auditory system must locate sounds in order to separate them and understand them easily in these noisy situations. So how do we locate and understand sounds in these noisy environments? Well, it's important to know that our auditory system, I've talked about, it must separate sounds out in order to locate and understand them. And then I'm going to talk about how listeners who wear cochlear implants actually experience difficulties locating and understanding in these environments. And before I get into that, I'm going to talk a little bit about how the normal hearing auditory system works so that we can understand how the cochlear implant system works. Okay, so how does the auditory system analyze various sounds? Take this word, Jane, okay? We're going to use that as a way to talk about how it travels through the ear. So this word Jane is first captured by the outer ear and then travels through the ear canal and vibrates what we call the eardrum. And those vibrations are then sent to the 3 tiny bones in the middle ear. But those vibrations are sent to the most important structure, which we've already talked about a little bit, called the cochlea, and it's a fluid-filled structure, but has a membrane that is organized in great detail, and that detail corresponds to the pitch of the sound. So once the information is analyzed there, it gets sent to the brain. Okay, so here's a short video of how that works. So hopefully this will work. All right, so the sound will travel from the outer ear down the eardrum, or down the ear canal, and then to the eardrum. And what you see is that if you kind of unroll the cochlea, what you see is that sounds of different pitches activate specific regions in the cochlea. So on the right here is, I'm showing you a depiction of what that cochlea would look like if I unrolled it. It's still kind of...
You should use this pointer.
Okay. So on the right here is that cochlea, and we're going to pretend that these colors kind of represent different pitches. And so that means that one region of the cochlea would be higher in pitch, and the other region would be lower in pitch. So that's how the cochlea is organized. Okay, so how exactly does the cochlea organize or analyze these sounds? Well, it's once it reaches the cochlea, it's broken down by pitch and sorted into bins. So ultimately, this word Jane is going to be sorted into the high-pitched parts of the sound, or the low and activating higher-pitched regions of the cochlea. And then the lower-pitched parts of the sound are going to activate lower-pitched regions of the cochlea. And so on and so forth. And all of those sounds, after they're sorted out, don't sound very much like the word Jane by themselves, but collectively, when they're combined together with the original word,
Jane,
they sound like the word Jane. So this is actually very similar to how you would deal out a deck of cards by suit. So that's kind of how your cochlea is organizing sounds by pitch. Okay, so the number of bins in your cochlea are actually much larger than what I'm showing you here. It's about approximately 40 of them. All right, so how is it, so let's talk about how the cochlea helps us separate and understand sounds of different talkers. So if you remember those male talkers in the room, they had very low-pitched sound voices. That means they were likely activating lower-pitch areas in the cochlea. However, Sheila's voice has a slightly higher pitch sound, meaning that her voice will activate slightly higher pitch regions in the cochlea. And when we observed kind of side by side, we see that there's a little bit of overlap, but this is kind of how your brain is able to separate those sounds out, because they're activating different areas. Okay, so what I haven't talked about yet is location. So location cues are also helping Bob separate Sheila's voice out from others, and having two ears actually helps you accomplish this. So if you notice here, since the sound arrives to his right ear before the left and is louder on the right ear before the left, he knows that Sheila is situated to his right-hand side. So how are location cues determined by our brains? Well, when a sound is presented to the side of someone's head, it reaches one ear before the other. And that means a small delay is created, and your brain uses that as a way to process where the sound is coming from, and that's called an across-ear time difference. And our brain computes this delay when a sound reaches one ear before the other, and we can tell in the horizontal plane where the sound is coming from. So these across-ear time differences are actually a fraction of a second. And so a change in that delay across-ear time difference tells us where in the horizontal kind of plane a sound is located. Okay, so when is the location cue useful? If you remember that noisy situation, he could just use other things like pitch or loudness to kind of figure out where Sheila's voice is coming from. When is the location cue useful? Well, it becomes useful in this type of situation. If you notice, there were other female talkers at the party, meaning they all have kind of similar sounding voices. So how do we tell them apart? Well, all of these talkers also have a unique location cue. So let's take, for example, Sheila and this other female talker. What you see is that for the other talker, her voice arrives to Bob's left ear before his right, telling him that the sound is to the far left. But for Sheila, the sound arrives to his right ear before the left, indicating to him that the sound is to the far right. So now we know that the across-ear time difference helps listeners locate and separate sounds in these noisy environments. It's really important for being able to do that. But now we want to know, how do listeners with hearing difficulties hear in those noisy environments? So a listener could be given a hearing aid, and hearing aids can help with amplification, making the sound louder, and sometimes there is damage in the cochlea, but amplifying that sound helps them hear out the sound better. However, what happens when that region has severe damage and it does not benefit from amplification and it becomes very difficult to hear? Well, for some listeners, this damage can actually span the entire cochlea and removes all of that detail organization that I talked about earlier. But for these listeners who have severe to profound hearing loss, that can be remedied with a cochlear implant. And so this is the external device, but then there's also an internal electrode array, which you've heard from Joe and Vijay, that there's an electrode array that is specific to certain manufacturers, but they tend to provide very good hearing outcomes for most listeners. Okay, so how does the cochlear implant analyze those sounds? So it's actually very similar to how the normal hearing system works. It bins the sound, again, it sorts them into different pitches, but there are fewer bins with the cochlear implant than the normal hearing ear. There are about 8. So most manufacturers, and that is relative to the number of electrodes that are implanted. There are about 12 to 22 depending on which manufacturer, but when they're being stimulated, only 8 are chosen at a given time. So the number of bins, so I also want you to pay attention to here in this signal is something called the fine acoustic details. So ultimately what happens is that information is removed, and we just keep the information that's the overall shape of the signal, called the envelope. So the envelope is a shape that's really important for being able to convey speech. So that is removed, and we keep just the envelope. But what do we do with the envelope? We use it as a template to fill in electrical pulses, and that ends up recreating the shape of the envelope very well. So those electrical signals are then sent to individual electrodes in the cochlea and ultimately to the brain. Okay, so there are 3 FDA-approved cochlear implant systems. There is Cochlear, Medel, and Advanced Bionics. So here I'm going to show you speech recognition performance for a several number of listeners by percent correct. So a greater value on this graph means that they have better performance and better speech recognition scores. So the bars are going to be color-coded by what manufacturer they have. And what you can see here is with 78 listeners, more than half the patients are able to understand 80% or more of the sentences, which is really good. But what happens when these listeners are subject to noise? What happens when they're in a noisy environment? Well, what we see is that less than a quarter of these listeners are able to understand speech more than 80% of the sentences that are presented to them. Okay, so if you remember, using that across-ear time difference in normal hearing listeners should be really helpful for hearing in a noisy environment. But if Bob had cochlear implants, does that mean that having 2 of them would help him hear that across-ear time difference? We learned earlier that having 2 ears should help you do that. Well, this is also a very relevant question because bilateral implantation is becoming more common, and it's becoming the standard of care for many children in many countries. So we can understand whether 2 cochlear implants are better than just 1 by presenting a sound from an array of speakers and recording the response that the listener identified. So we measure performance in a degree of error. So let's say the sound is being presented from the center and the listener hears it slightly to the right. So the difference between the response location and the actual location is the amount of error that in this task. And so a degree of error that is small would indicate that they are a good performer. So for normal hearing listeners, normal hearing listeners have a very small degree of error, about 8 degrees. This means that a normal hearing listener is only incorrect by an 8-degree horizontal shift. However, a listener wearing just one cochlear implant has a much larger degree of error, around 80 degrees. Whoops, oh my gosh, what did I do? Okay. But for listeners wearing 2 cochlear implants, they have a degree of error that is larger than a normal hearing listener, but much smaller than if they were wearing just one cochlear implant, so about 30 degrees of error. So it would seem that hearing with 2 cochlear implants is better than hearing with 1. So why is hearing with 2 implants not as good as having 2 normal hearing ears? Well, it's because that across-ear time difference I talked about is missing in current cochlear implants. And the modern cochlear implant was originally designed to relay speech information for just one implant. So really, they're not designed to work together. They're not designed to be coordinated or synchronized in time. And you can clearly see here that the clinical processors are fit, even though they're fit independently in each ear. They're fit independently in each ear, even though patients may have 2 of them. So in our lab, we use coordinated cochlear implants, and our goal is to send precise timing to both ears, and to overcome that lack of across-ear coordination and time of the clinical processors, and restore time differences so that listeners with bilateral cochlear implants can hear in noisy environments. In the lab, we have some control of this engineering with these research processors, and they allow us to control the signals between the 2 ears as close as possible so that we can present the timing difference very precisely. Okay, so how do we do this? Well, what we do is we bypass what the microphone is picking up, and then if you imagine that this implanted electrode array, just imagine that it's unrolled, we can present the correct timing information to both ears that are synchronized in time through this device. So if you remember what our electrical pulses looked like, these electrical pulses clinically, they operate at very high rates, but that also means that they're moving too fast to convey an across-ear time difference. So let me try to explain what I mean by too fast. So how fast an electrical pulse is moving is going to be represented by a yellow flash in each ear. So for a sound that is coming from the left-hand side of this person, you'll see that the left ear flashes before the right. The listener obviously knows that the sound is coming from the left because it's arriving to the left before the right. However, if I increase the rate of those flashes, it becomes harder to tell which ear is flashing first. And after a while, this makes it more difficult for the brain to tell which direction the sound is coming from. So ultimately, a high rate prevents you from being able to tell the direction of the sound. Okay, so then the idea would be then maybe we should present just low rates to the electrodes, to all the electrodes in the cochlear implant. The problem with this is that it doesn't recreate that shape of the envelope very well, this speech envelope that I talked about. So if I show you the envelope here and then I remove that shape, you can't really tell what the original shape was supposed to look like. It should fill out more. So for detecting the location using a time difference, it seems that low rates lead to better performance, but high rates do not. Alternatively, for speech understanding, we find that high rates are better for speech understanding, while low rates are not ideal for speech understanding. So for listeners with cochlear implants, there is a trade-off between locating the sound and understanding the speech. So a lot of my work in the lab has tried to take the best of both worlds by mixing the rates. So that means playing some high rates at some electrodes to give that speech understanding, and some low rates at some electrodes to be able to give that across-ear time difference. And so far, the current technology really just uses this high rate stimulation, but we wanted to find out if these mixed rates could provide a greater benefit. Okay, so how do we explore if mixed rates will help with localizing a sound. So again, we used those synchronized research devices, and we asked listeners, where did you hear the sound? And they have to report on an image of a face where exactly they heard the sound. Okay, so now I'm going to show you what those responses would look like on a graph. On the right-hand side here of the slide, I'm going to plot the location and the location cue on the bottom axes, on the horizontal axes. And this half of that graph is going to represent sounds that are coming from the right, that we're playing from the right-hand side to the listener. And this half of the graph is going to represent sounds that are being presented from the left. And the responses are going to be on the vertical axes here. So the listener could respond that they hear it anywhere from the right, center, or left. Okay, so let's say we present a very large across-ear time difference to this listener. And I'm going to just show you the value of it. It's 800 microseconds. So just for reference, 800 microseconds is about 10,000ths of a second. So it's a very small delay, but our brain interprets that as it's coming from the far right-hand side. So we play that sound to them as coming from the far right-hand side. And let's say the listener says, I hear it to the far right. So on this graph, we would mark that they heard it on the far right. Now, let's say we play a slightly smaller time difference, so around 400 microseconds, so it's not all the way far to the right, but still a little off to the right, and the listener says they hear it somewhat to the right. We would mark that on this graph as well, to the right. Now let's say we play a large time difference coming from the left, so that would mean 800 microseconds to the left. The listener would hear it coming to the left before the right ear. And then we would mark on this graph that they heard it to the far left. And finally, let's say we played no timing difference. That means there's no difference across the ears. So a value of 0 would be put on this graph, and the listener says that they hear it in the center. So we just mark on the graph that they heard it in the center. So what we're looking for is really a function that looks like this. An S-shaped function would tell us if their responses fall somewhere close to this, then they're hearing the across-ear time difference very well and able to tell us left from right very well. Okay, so next I'm going to show you some performance or some data from two bilateral cochlear implant listeners. This is listener A. So again, on the vertical axis is going to be their response, whether they heard it to the right, center, or left. First, I'm going to show you when we present only low rates to them, meaning these are not clinically available, but they should be good for giving that across-ear time difference to them. And what we see is that S-shaped kind of curve. These listeners are able to tell you left from right very well, but it's kind of what we expected because we know that low rates are good for that. Now, if we look at the high rates, which are used clinically, we see that their responses are not, they don't hear sounds to the left and right very well. And that S-shaped function is kind of missing. But if we looked at the mixed rates that we've developed in the lab, function is kind of restored in their responses. They're able to hear sounds left to right very well, and they're mapped to this kind of S-shaped curve again. Okay, and for one more listener, we see that for the low rates, again, they're hearing sounds left to right very well. And for the high rates, which are used clinically, there's not able to have that full range of responses like the low rates. And when we test with the mixed rates, we see that their responses for hearing sounds left to right are restored. So the idea is if Bob had cochlear implants or needed cochlear implants, if he was in this noisy situation again, you might be able to hear exactly what Sheila was saying.
A large size in stockings is hard to sell.
And he'd also be able to tell that she is on his far right by using the location information. So just to summarize, listeners with bilateral cochlear implants struggle with hearing in noisy environments, and it's because that across-ear time difference isn't available for being able to locate and separate those sounds. But our lab is investigating new ways to improve cochlear implant processing to restore those time differences. And we're also looking into other things like how much effort people are exerting in those noisy environments, but also we're looking at using new devices that actually are already synchronized in time and looking at their performance with those devices. So just want to say thank you to everyone in my lab, and I will take questions.
Is it true that most of your research has been done in individual with two cochlear?
Yes, the question was, has most...
I haven't finished.
Oh, sorry.
Since most adults have only one cochlear, is there any way that your research can shed light on localization with individuals with only one cochlear?
So the question was, has most of my research been done with listeners who have two cochlear implants, and can this shed any light on listeners who have just one cochlear implant? It's a very good question. So my work has been done with listeners who wear two implants. However, a lot of our work does also look at how listeners are able to separate a speech from a noisy situation with wearing just one cochlear implant. And sometimes it depends on which ear people prefer, the left or their ear with the cochlear implant or their ear with the acoustic hearing. And sometimes the timing difference is not the best way to convey the location or being able to separate sounds. However, we're still looking into it, and there's a lot of work with people we're collaborating with who have tried to look at how a time difference could be given to listeners who have acoustic hearing in one ear and a cochlear implant in the other ear. Mm-hmm.
I wear hearing aids, and I know there's a slight difference between, I tend to favor one ear more than the other. I have no experience with a cochlear implant, but if somebody has two cochlear implants, do their ears function the same, or is there still that same difference?
That's a very good question. And the question was, do listeners who have cochlear implants, who have two cochlear implants, have a preferred ear, you're saying, and if they function differently? There's one really great graduate student in our lab, Emily Berg, working on this question, and she is finding that there are asymmetries in performance across the ears, and she's looking into how that impacts both how much effort they're exerting in a noisy situation, and if they favor one ear in most situations. So we're still trying to answer that question, but yes, most people do have a preferred ear. Yes.
More in the quality of sound across the spectrum of average between bilateral, say at the same time they're implanted. What is the quality of sound difference that you've seen? In other words, speech recognition with one device off, one device on, do they generally perform equally, or is that such a...
So are you asking, does the signal look differently, or?
Each ear here, how average to equal does each ear hear in your typical bilateral implant? In other words, the quality of your speech recognition.
That's
both at the same time. You listen from just one ear and listen to the other. What's the performance like?
right. That's so the question was, I think, what is the performance with just each ear alone?
Yeah.
Oh.
What's the performance difference? How often do they hear equally, and how often are they just in different spectrums?
I almost want to give this question to Emily because there's a range of listeners where they have. So the question again was, how different in performance are their two ears in speech recognition? And the answer is that it varies. There are some listeners who have very large asymmetries in their performance, and some listeners who have very small asymmetries in their performance. But we don't know exactly how that impacts their ability. I mean, we don't have a full picture yet of how that impacts their ability to actually use both together in a noisy situation. Jack.
One last.
Oh,
This is your last
okay,
one.
yeah, okay.
Does age make a difference in terms of time of implantation, cochlear implant activation, say early on, like not having any good location skills? Can people learn this, or is it something that's kind of innate and you need to learn from an earlier age?
Okay, so the question was, does age impact, age of when you got implanted or age just in general?
Does age have a difference, make a difference in terms of being able to learn sound vocalization?
So the question was, does age impact your ability to learn sound localization? And generally, sound localization, your ability to kind of tell where sounds are coming from is inherent. So if we're talking about adults, usually that mechanism is intact and has already been kind of solidified from when you were a child. So your ability to kind of detect those time differences should be there, but it sometimes is limited by, you know, how long you didn't have, how long you may not have had hearing exposure. But for children who may have had been deaf from birth, they do struggle to kind of localize sounds the way normal hearing listeners would, because they haven't developed those underlying kind of mechanisms.
So it's a developed skill.
Somewhat, yes.
Yeah. Thank you, Tammy.
Nice job. Use that to
So thank you so much to Tanvi Tucker for a wonderful presentation. We are now welcoming members of our community panel to come to the table in front of you. And after they sit down, we will get started. Is this now on? Yes. So because we have had some interesting challenges with our microphones today, I was told to Phil Donahue the event, which I think means that what will happen
months for me to adjust and get used to the sound of the cochlear implant. So there's a lot of coming home from school and sleeping just to kind of adjust and get used to all the stimulus that was going through my brain. And so finally overcame that and have been very, very blessed and successful with the cochlear implant ever since. I'm currently a ERP consultant for Baker Tilly. So I do management consulting for a steel company. So I implement a system called Plex. And so it's a lot of dealing with client requirements and learning what they have to say and then inputting the requirement into the software. So the cochlear implant definitely provides an outlook to hear the clients and have what they have to say and be able to communicate effectively with them. So I'm very happy to be here. Thanks everyone for coming.
Hi everybody, my name is Melissa. I have a daughter who's 3 years old now, and she has bilateral cochlear implants. She was implanted at about 18 months old. When she was born, she passed her newborn hearing screen, and in retrospect, we realized she probably should not have. But it took us about 11 months to figure out that she was deaf on her own. She was very, her babbling wasn't progressing, but at the same time, it would seem like she would turn when somebody rang the doorbell or when somebody entered the room. And so I said to a friend one day, I'm just not sure that she can hear. And my friend said, well, go home and bang some pots behind her head. And I did, and that's kind of what started our journey. And then it took, a good 6 months before we could actually get into the healthcare system, get the bear test and the official diagnosis. She had to go through the trial of hearing aids, and then at 18 months she was implanted. And it has been life-changing ever since. She's very talkative, very social. She goes to 2 different preschools. We're doing intensive speech therapy with her and audiology training, but it's incredible.
Hello everyone, my name is Pete, and I started to go deaf when I was around 50 with due to Meniere's disease. It started on the left side, and I thought I'd just be living a life with hearing on one side, but eventually it got to the other side as well too. So I spent some time with a cochlear implant, and then as the hearing started to go on the right side, I also had a hearing aid that seemed to work for a while until the hearing went so bad on the right side that I had to go for the implant. I had to be deaf enough, according to the insurance company, before they would implant me. So unfortunately I had to leave work for a while. I left in February and was able to get back in October with the help of my school district, which was wonderful. Played around a lot with the right kind of phone for me to use. That was the big thing, because my job has a lot of phone contact, so it took a while to find the right phone. The other thing I'm going to say is I think cochlear implants are a miracle. I just can't say enough to the people who are the brains behind it, and it really pays to have a wonderful audiologist because they are your lifeline. I'm a little slow to take up technology at times, so I really like it when I have my appointments with Jennifer, because she always helps me out and helps me grasp things that I'm a little slow on the uptake. So they're a wonderful product.
Hello everybody, Mitch Musteri. I lost my hearing at age 4. I was born into a completely normal family, whatever normal is, but there is no history of hearing loss in my family. I progressively lost my hearing from 4 to 12, and during that time there was never any sense of what was happening. But at age 12 I was able to get a cochlear implant on my left side. I was actually part of a research study at the University of Iowa. Dr. Bruce Gantz was my surgeon, and ever since then I've just had a huge passion for always giving back to the hearing community.
There's feedback.
Okay, there you go, sweet. All right. But I don't know what I was talking about. But anyways, yes, it pays to have a great audiologist. And ever since I've had my cochlear implant, I've seen life-changing success. I've always wanted to be able to play sports, do any job I wanted to, and I've actually been in sales for the last 10 years, so I'm making cold calls, in loud and noisy places, and then as of this year, took over as a sales manager for a hearing diagnostic company. So basically anything you see inside a sound booth and outside a sound booth, I'll be selling. And even though I'm not an audiologist, it pays to be deaf, so then you get some credibility from the audiologist I'm working with. So. But that's enough for me.
Hi, my name is Becky, and I had gradual hearing loss throughout my adult life. And I was calm and collected because now I realize I didn't hear all my kids and how noisy they are. So I struggled at work. It got progressively harder to do my job because I couldn't hear. I tried to get cochlear implants and was denied by my insurance company because I wasn't bad enough. And then a few years later, we appealed. I took my boss with me, and she had to say, well, I would fire her because of her poor hearing, but I can't do that. And so then the insurance company agreed, and I was implanted in 15 and got turned on right before Christmas. And at first I didn't hear anything. It took a few weeks to start hearing things. It was winter, so the first time I heard the letter S was the word snow. I thought, I think I heard the letter S. And then I could hear went to church and could hear the Christmas carols and hear the words. When we opened the presents, I thought, oh, this is all this crackly paper that my family complained about unwrapping presents. And then cooking for my family, I made pancakes, and I heard the S, the sizzle of pouring the pancake batter on. It was like, I haven't heard that for 30 years. So it was wonderful, changed my life. I continued to do music, and I had perfect pitch, and my residual hearing was allowing me to still do music. When I got the second side, I lost my perfect pitch. So it greatly changed how much and how I can do music and how I can enjoy music. I've kind of gone back to it now. I play the keyboard, and the pitch is in the instrument, so I don't sing anymore, but I play the piano in a variety of situations and still do a little bit of choral music. And then we wondered, my husband, he's here, and we wondered, well, would an implant help our help our marriage or ruin it? Because now I can hear all his jokes.
Good morning. My name is Kathy Johnson. My hearing loss was actually discovered when I was 5 years old. At that time, my brother was having issues hearing, and they suspected he had a hearing loss, and so they took me along and got my hearing tested and found out I had moderate to severe hearing loss. So I wore hearing aids since I was the age of 5. When I hit my late 30s and early 40s, my hearing started to deteriorate quite a bit. And we did all kinds of testing and weren't able to determine why my hearing was going. And so finally, at the age of 45, I was able to qualify for a cochlear implant because I was not deaf enough. But mind you, my testing scores were quite bad. But it was truly a blessing. So I've had my cochlear implant for 11 years. I still wear my hearing aid in my other ear. I have severe to profound hearing loss in that ear. So someday I will be facing another cochlear implant. But it truly has been wonderful. You know, I was at the point when making the decision whether to get a cochlear implant I was more scared of what would happen if I didn't than if I did, because it was getting really tough to do my job. And I am the privacy officer for the Wisconsin Department of Health Services, and I do a lot of interaction, communication, meetings, phone calls, conference calls, and now that is just a breeze. I don't need any assistance. I can hear on conference calls without assistance. It gives me a thrill each time I do that. And sometimes I get frustrated because I don't always hear things, and my daughter, who is hearing, reminded me that even normal people have problems hearing sometimes. So remember that.
Yes. Thank you, everyone, for introducing yourselves and sharing your histories. That was tremendously helpful, I know, to our audience. I'll come up and get that question. Thank you. So one common question that has come up has to do with 1 or 2 cochlear implants, and people here have made certain choices about when and whether to transition to having a second implant or continuing to use the hearing aid, continuing to use 1 cochlear implant. And if anyone wants to address that question, I will pass the mic around. Thank you.
Well, like I mentioned, I still have a hearing aid, and with the hearing aid, I am still getting a benefit. As a matter of fact, I score 99% in quiet. And without the hearing aid, it's 96. So as long as I continue to get a benefit, I will continue that route, because I know the technology keeps getting better and better. But I know I have a lot of friends that say, oh, 2 is fantastic. So that's where I'm at.
So I have a little bit of a biased opinion, even though I am a unilateral user. I worked in Roots Lab for 2.5 years, so I understand the research behind getting 2. I will say though, when I got my implant back in 2000, there really wasn't an option to get to unless you had a ton of money that you could shell out. Nowadays with insurance and those options, I think if I had the opportunity to get to at the same time, I would. It's just, I can't stop my life and put it on halt to get the surgery unless I have to. But right now I get by just fine with one in my opinion. But if I had to go back in time and I could get two at the same time, I probably would.
I really debated on going or getting a second implant. Our problem was we had to fight a lot with our insurance company for the first implant, but I think things have come a long way since then. I too am kind of holding out for the technology portion, kind of wondering, it seems to get better and better all the time. Also, I have heard of some research, but I've been told it's not going to be in my lifetime, but where they're actually regenerating the cochlear hairs, or possibly regenerating cochlear hairs. I don't know. I thought I read a couple of things about that. So, boy, that'd be wonderful. But my understanding, if you have an implant, the hairs are damaged too much to have that happen. So maybe an expert can talk more about that.
There's a bit of feedback going on. Okay, there we go. Better. Thank you.
So I have a cochlear implant in my right ear, hearing aid, phonak in my left. I really like the sound of my phonak hearing aid. I've been hearing with it ever since I was 3 years old. I really like the sound of music out of the hearing aid, and it's just very different and unique from the cochlear implant. However, I do know the benefits of having two versus one. My girlfriend Emily, she works with Ruth and Shelly, and she tells me every day, "Hey, you need to upgrade." And so I know, and I experienced it firsthand. One of the downsides of having one versus two is the localization of sound. So if I'm walking down the street and someone's yelling my name, I have no idea where they are. No idea. And so I'll search around, look around, and then finally I can localize where they're yelling my name from. But apparently that's the best benefit, one of the better benefits of having two versus one. And so I can definitely use that, and I plan on implementing or getting the second one relatively soon. I just need to find the right time to do it.
Is Clark in the room? Sorry, I'm just trying to figure out how to turn off the feedback. Oh, there we go.
Well, since I'm the one up here with bilateral implants now. I said it was the downside was I lost the little bit of residual hearing I had for hearing pitch and music, but it has greatly improved my safety because I can localize sound, and so that makes a huge difference if I'm walking or biking, or I can think, oh, I can hear that coming up behind me, or locate sideways, and it helps. We have a handicapped daughter we take care of, and she has various alarms and beeps, and now I can localize, oh, that's her sound, whatever the sound is. So I think that it's helped me in speech, localization, safety.
Thank you. And on that note, there was a question about what happens with sounds from behind, and is it something that's dangerous? And I heard you say that you can tell if sounds are coming from behind or in front, but that might be variable for different cochlear implant users. And so there was a question about how you deal with that and whether you know of improvements down the road. I can add to that cochlear implant companies are continuing to try and partner with hearing aid manufacturers as well, because a lot of the algorithms that were developed for hearing aids can really be implemented in cochlear implants to help us know if sounds are coming from behind or in front, and improving safety in the real world. Does anybody want to add anything about that, or your own experience about that? Okay, so we have a question from Melissa, the parent of a child who got 2 cochlear implants at a young age. And there are a couple of questions. One is, did you use ASL, and if so, to what extent? And then I'll ask the next question.
Okay. Yeah. So
yes,
As soon as my husband and I realized our daughter was deaf, like I said, there was a long time between our realization and when it was recognized by the medical community with an official diagnosis. So we decided to adopt ASL as quickly as we could until we could get her hearing and speaking. We had heard about the show Signing Time with Rachel Coleman. Her daughter has a very similar story to ours. And we let our kids watch as much Rachel Coleman signing time as they wanted, and that's kind of how we all learned at least basic signs. But with that, we saw our daughter learning language. So one of her first signs was baby, because she loved her baby doll. And at the time, there was kind of a lot going on with our daughter that we didn't know if she had cerebral palsy or what her issues were. And just seeing that she could learn these signs so quickly alleviated a lot of fears with regard to that, and we just saw her blossom. So we continued with the sign language. We still now even use some sign language, although our focus is really on auditory verbal because our family is all hearing. But at school, her teachers do use some sign for disambiguation, and starting in the fall, she'll be in the public school and she will have her own sign language interpreter in the classroom. So I think that was the full question on that one.
Is there a trick to keeping the devices hooked? And given Vijay's presentation, what's your trick?
Yeah, so, and that's funny, we were just all talking about this prior to the panel. We found using wig tape, tape that is for men and women's wigs. We use a tiny bit of tape between her ear and the processor, and that keeps that on all day. She's 3, she's running around, she's playing, she doesn't want to deal with it. So that keeps it on all day at school. When she first got the processors and the coils, well, between her throwing them off and them just falling off, our apps, she has the Cochlear Nucleus 7, were showing that they were coming off about 300 times a day. So now it's way less. I mean, and now the processor will stay on her ear, and if the coil falls off, she'll often put it back on herself. That wig tape has been huge, and like I said, we just cut it so that it's a real small amount. It's very gentle. It's not like medical device. It's not like medical tape. So it's very gentle when we take it off, and it's worked beautifully. Other people have used something called a hearing Henry. It's kind of like a headband. Our daughter wanted nothing to do with that. She didn't want something on her head. It is kind of cumbersome too. And then we also have a little unicorn retention cord, so that when they do fall off, they're not in the sandbox. They're attached to the back of her shirt. And those are kind of our big trips. But the wig tape was life-changing. So.
That's great. I'm going to move on to a different topic, which is tinnitus. Because there are some questions, and if any of you experience tinnitus, and then what is the side effect, or what kind of improvement did you see? People would like to hear about that.
Meniere's disease, one of the factors with that is tinnitus. So that was actually the first thing I started experiencing when I turned, right around when I turned 50, so it was my 50th birthday present. Tinnitus started, and I just thought, okay, my dad had it, it's just something I'm going to have. But of course, then the vertigo came later, so then I knew we had something else going on. But basically, for me, I have it every day, all the time. I pretty much just got used to it. I know some people it really drives them crazy, but I've tried different things, supposedly different vitamins, different things to help get rid of it, but I haven't found anything, and I think over time I've just gotten used to it, and it really doesn't seem to bother me too much anymore.
I also have tinnitus. As a matter of fact, when I was in the hearing booth, sometimes I have a hard time telling if it's my tinnitus or the beeps. Very challenging, but I just find that when I keep my devices on, I don't notice it as much.
Thank you, and I just wanted to add that we have been studying the effect of having a cochlear implant on tinnitus, especially in a group of patients where there is no approval yet by the FDA, but there's a growing number of patients with single-sided deafness who also have tinnitus. And for that, quite a few surgeons, a growing number, are now offering cochlear implant as an option. And there's a remarkable report of reduction in tinnitus when the cochlear implant is on. So during the day when it's on, tinnitus can go down from 90%, which is really almost debilitating, to very, very little. And so we're seeing that in a growing number of patients. So if you know anyone with single-sided deafness who's also experiencing tinnitus, I'd be happy to put them in touch with surgeons who could also try to help them get coverage by health insurance, which is again not universal because this is not indicated yet by the FDA, but there are clinical trials right now. I think I'll leave your question in a written form, or if you want to.
Can somebody define tinnitus?
Can someone define tinnitus? So it's not my expertise exactly. I can tell you what the literature says, which is really the ringing in the ear that people report that isn't due to an external sound outside the head. So tinnitus or tinnitus is this ringing in the ear. It's not from outside the head or an environmental sound. The cause is not exactly known. There are a number of theories about where in the brain, where in the auditory pathway, there's this disengagement of certain connections that leads to you hearing sounds that isn't actually being presented from outside the head. But the ringing in the ear can be really, really debilitating. Okay, so now there's a question about just your general use of the cochlear implant during the day and at night, and sort of what choices do you make about that? Are you an all-day wearer? Are you a night wearer as well? Where do you fall along that line? Who wants to take this first?
I'll start
with me.
So I'm a firm believer of getting as most benefit as I can. So I've trained my 3-year-old daughter to get it for me in the morning and bring it to me when she wakes me up. So usually at 5 o'clock every morning, she's got my rechargeable battery and my top part from the dryer. No, I'm kidding. But really, I do wear it for a minimum of 18 hours a day. When my daughter was an infant, I didn't want my wife to feel like she was shouldering the full load when my daughter would wake up in the middle of the night. So instead of spending a ton of money on buying one of those monitors that connects to your phone, we bought the Gerber monitor that vibrates, and then we bought a separate monitor that had the screen, because apparently they didn't want to make one under $400 that does both. And so I would wear my implant 24/7 for a while, but for me, the battery life would just obviously not sustain, and then I also would just get some slight headaches just because I was wearing it so long. But that's my input on it.
I basically wear mine all day, but in the morning I find that I take my time putting it on. I'm not quite sure how that developed, except I think in the very beginning, I tried to grow my hair out pretty long, so I was having issues with the cosmetics of it. So I went through that little vanity piece for a little while until I realized that I just needed to embrace it. So I wanted my hair to dry before I put the implant on, and so maybe that's where it all started, I don't know. But I do kind of like having the quiet time in the morning. I think there is a silver lining here from the standpoint that I can control when I hear and when I don't. So, if there's obnoxious noises in the neighborhood at night and you're trying to sleep, thank goodness I can turn off my hearing, if that would be a need for me. So, but in the morning, it's kind of nice to have a quiet time. Also, I think even though this causes no pain and it doesn't really get irritated, there's something about having something on your ear all day long. So it is kind of nice to have some waking hours without having something on my ear.
So I'm with Mitch and Pete. I can't survive without it, here without it. So I actually spend 18 plus hours every day wearing the cochlear implant. So on a side note, I actually spend a lot of time without wearing my hearing aid. So I'll go several hours of the day without wearing my hearing aid. Sometimes my ear mold bothers me a bit, so I'll just take it off and just survive on just the on the cochlear implant, and I actually perform better with just the cochlear implant, but I just like the sound of the hearing aid, so that's the reason I wear it. And it's just an ever so slightly decrease of hearing when I have the cochlear implant on and the hearing aid. So it doesn't really matter whether I have it on or off, but I'll take my hearing aid off occasionally throughout the day just to give my left ear a break.
I wear mine about 17 or more hours a day. I take them off at night because I am a very light sleeper, and thank goodness I can block out all the sounds. Unfortunately, my husband is a very sound sleeper, so I can't rely on him to save me in the middle of the night if something should happen. Because before, I would wear my hearing aids with my cochlear implant, and I would hear something go bump in the night, and I asked my husband, do you know what that was? Never heard it. Anyway, what I do at night then is I have devices that will help alert me, such as a doorbell or the fire alarm going off. I have it connected to a bed shaker, so it will wake me up in the event that happens. And in the morning, I like my quiet time too. I just don't like to start off right with a cochlear implant. I start out with my hearing aid, and I warn my family I don't have my ears on because they, will start talking to me and realize, oh, she's not understanding me.
Thank you. So really on that note of when you wear the cochlear implants and safety-related issues, there's a question from a parent who just had their daughter bilaterally implanted on Tuesday. And they want to know, again on that note, what do you do at night if you keep the implant off as far as communicating with your child, as far as safety, that sort of thing? Do you wake them up, or do you put the implants on while they're asleep, or what is the best approach? So we'll start with Melissa, but then if anyone has anything to add, that'd be great.
Yeah, so when our daughter does not have the implants on, it is a lot, that is when we rely on sign language. And again, we are not, we are trying to learn sign language, but, we use the sign language we have. And then otherwise she does do some lip reading even at age 3, and it's a lot of, we have to be right in front of her. And of course, if you're in a different room and she says, "Mommy," you can't just say what, you have to come and look at her face and talk to her, do sign language with her. So at night, in general, she does not wear her implants at night or when she naps. The past week or so, she's been wanting to leave them on at night. So she'll fall asleep with them, and then I get a notification when they're on the wrong processor or when they're disconnected. So I know pretty quickly that they've come off, and we just leave them off and have her backup batteries ready to go for the next morning. And the other thing I was going to say is, so as far as safety, right now she's only 3, so she's always with us. But when she's older and maybe there's some more independence, we do plan on getting the devices that strobe lights or vibrate, because when they are off, it's a different world, right? And it's sometimes hard for hearing family members to remember, because she is doing so well with talking and communicating. It's hard for hearing members of our family to remember, Vivian won't hear that, or she won't recognize that that's a fire alarm or whatever. And the water coils. She has water coils, so in the bath time, we put the water coils on her. We want her to hear the water coming out of the bathtub. We want her to hear splashing. That way we can communicate with her in the bath. We could use sign too in the bath, but it's a nice time for language learning in the bath with toys and stuff. So I think that was the question.
Anybody else want to add about nighttime?
I guess when I was younger, I had 3 older siblings, and my parents were obviously involved. They would always, at 12, I could still read lips very, very well. So depending on how old this child is, they probably don't have that yet. But I did learn American Sign Language as well. So if it wasn't for sign language or lip reading, it would be very hard to communicate with me without my implant on. And until recently, when Cochlear added their covers for wearing the implant in the water, nobody could communicate with me when I was swimming. And so that was probably the hardest time, but usually you come up with your own signals or whatever that notifies them of a way of getting their awareness. Luckily with me on my right ear, I still have some low frequency hearing, so I can still hear somebody trying to signal me, but I just won't be able to understand them until I'm looking directly at them.
Great. Well, we're almost out of time, but one of the last questions is really about what is it like to hear with a cochlear implant? Some people think it sounds like bionic hearing or electric hearing, and many people who use implants say, no, it sounds like sound used to sound like. And then if you want to also address what it's like to use a telephone along with that, we'd love to have you answer that as our last question.
I think cochlear implants sound normal. I mean, I don't notice any difference. I know that I have to get a map twice a year because they start to sound a little off on certain electrodes, and it just drives me nuts. Phones are not a problem for me. I do have a caption phone at work that I used before my cochlear implant, and I would turn that on. Every once in a while I get a message I can't understand. And so I play the closed caption, and they can't understand. But I have no problems with phones. I can use a cell phone or regular phone without any issues.
Yeah, I think the sound quality is what I remember. So.
Yes, I mean, upon initial activation for me, the cochlear implant did sound a little bit like a radio without, an exact signal. And back in the day when radios had antennas, but after a week or two of wearing it, that quickly went away, and it sounded exactly like I remember normal hearing sounded like. But if you don't get to Kathy's point, if I don't go in once a year to get my maps reprogrammed, some sounds will start to come together. My wife's convinced that I don't hear her as well, but that all sounds like me, just my selective hearing. But just keep that in mind.
Because I had hearing and then I lost it, I pretty much know how people's voices in my family sound, and it is exactly the same. I did not have any or notice any difference in sound quality from before and after the implant. Telephone use for me depends on the person on the other line in terms of the fact, do they talk down, away from the receiver, do they mumble talk, do they talk really rapidly, and you have no control over those things, but to me that is all the difference. I think most phones work pretty well as long as the person is speaking, into the mouthpiece. I think it works out pretty well for me. I will just add music for me. I'm stuck in the 70s now, that's when I grew up, so all that music seems fine. I put on Cat Stevens and I can hear her and understand that really well. Introducing new music to me is difficult. I have a hard time with that.
So I had also had this question, so this is interesting for me to hear. I will say regarding the mapping, when my daughter first got the cochlear implants, it took a couple different audiologists until she seemed to get a map that worked for her, and then she started asking for her processors. And we can see a difference. We call it leveling up, my husband and I. When she goes to get a new map, we'll hear all of a sudden, her articulation is better, or she's saying new sounds that she hasn't said before.
So I'm going to go against the grain a little bit. I believe that the hearing aid sounds a little bit more natural for me. However, I just can't hear with it. I only hear low frequencies. I hear all my high frequencies through my cochlear implant. So the first time I heard a bird chirping was at the age of 14 when I got used to the cochlear implant, all the S. And so I required to use the cochlear implant, and it became more and more natural as the years progressed, and my maps have become more fitting for what my hearing loss is. And then in regards to the phone, I recently upgraded to the Cochlear America N7 that has Bluetooth capability. And so whenever I have my Bluetooth on and I get a phone call, it goes directly to my ear. I answer the call, and then I hear it through the ear and I talk through the phone. It's amazing, life-changing. It's the best technology that I've experienced thus far, best enhancement thus far for the cochlear implant, and I use it every day to receive phone calls, listen to music, listen to podcasts. It's been great.
Well, thank you for those really insightful answers to a lot of amazing questions. We couldn't get to all the questions. I can't thank you enough, our community panel, for being here today and for being such great ambassadors for both the experiences and the success and the challenges of using cochlear implants. So please join me in thanking our panel. And what we're going to do in a minute is transition to our clinician panel. But right as we're doing the transition, a couple of our researchers wanted to make a quick announcement to our audience today. So as our clinician experts are sitting down and as we change up the note cards, the name pieces, come on up, Jacinia and Sarah, and make your announcements.
Thank you, Ruth. Hi, my name is Jacinia Hartman. I am a graduate student in Dr. Ruth Thompson's lab. I'm looking to recruit people for a current study. Actually, we're both looking to recruit CI listeners for our study. My study is a word learning study, so it's looking to see how well CI listeners learn words in different learning situations. The experiment will consist of listeners learning new words, and it will only take about 2 hours to complete. I'm looking for unilateral and bilateral population, and the purpose of the experiment is to improve or to find new novel approaches in order to improve word learning outcomes in CI listeners. My name